Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing a fascinating new way for doctors and other health professionals to create treatment plans tailored to patients' unique characteristics. My guest is my colleague, Dr. Karina Davidson. Dr. Davidson is the Senior Vice President for Research at Northwell Health and a Professor of Behavioral Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. She is also the Director of the Center for Personalized Health, which is part of the Feinstein Institute for Medical Research at Northwell. Dr. Davidson was recently awarded a major grant from the National Institutes of Health to advance this kind of work. Karina, welcome to Well Said.
Thank you so much, Ira. I'm delighted to be here and talk about personalized trials.
So before we get to that, just tell me how you've been doing over this most extraordinary past year.
It has been a year of ups and downs, hasn't it? I've been incredibly grateful for the colleagues that I've had here at Northwell, as well as all of my team members, but there's certainly been some challenges to overcome, and I'm looking forward to all of us spending more time together next year.
Yeah, amen to that. So congratulations on the establishment of the Center for Personalized Health. And before we discuss what that's all about, I'd like to start by reviewing for our listeners the way that doctors generally choose what tests and medications to recommend for patients now. Isn't it already the case that physicians take individual patient characteristics into account? I mean, to take a simple example, we don't treat kids the same way we treat adults. So how is what you're talking about different?
So you are right. As of this moment, all doctors take into account individual patient characteristics and preferences. But what they have to do, which is really onerous for them, is they have to read the literature about all of the evidence-based randomized controlled trials in an area. And then when they're following evidence-based practice, they have to summarize all of those findings in their head. They have to think about the individual in front of them and all the things that make that person unique, and then think about their preferences while they're using their clinical judgment to take the results from other patients and apply it to the patient in front of them. And what's critically different about what we're proposing is that they're going to collect data on the patient in front of them, and so use data from that patient to figure out what's best for that patient.
So let's try to work that through with a specific example. So I personally treat a lot of patients who have high blood pressure, and so in the current model, what you're saying is what you just described is what I do, I guess without thinking about it too much, is I know what blood pressure medicines work for most people because they've been studied in large numbers of people. And I pick one of those medications because I think it will work for the patient in front of me, and we sort of give it a try.
Right. And what's different about what I'm proposing is you might, from your vast knowledge of hypertension, know that there are, say, 3 first-line treatments that might be possible for this patient that from other patients have generally worked well. And what you would do in this approach is you would ask the patient if they wanted to work with you to spend a little bit of time figuring out the lowest amount of treatment for the biggest effect with the fewest side effects. And then you'd send them home with those 3 different medications and a blood pressure monitor. And they would be getting a text each morning saying, today take the pill from bottle B and take your blood pressure. Now, tomorrow, take the blood pressure medication from bottle C and take your blood pressure. And at the end of 12 weeks, you and your patient could sit down and see what was their average blood pressure response to each of the 3 medications, and when did they have side effects. And from there, you could help work with that patient to figure out the medication that worked best for them with scientific precision or personalized trial information.
That really kind of turns the whole enterprise on its head a little bit, right? Because what we're saying is, instead of doing clinical trials or research on large numbers of patients and then applying that to the patient in front of me, we're actually using that patient in front of me as their own research subject. Does that summarize it?
That does summarize it nicely. And sometimes I say to people, not even as their own research participant, but as best clinical treatment. You're using science at the clinical encounter to precisely identify the statistically different treatment effects and side effects for that person.
I use the term personalized medicine, but how does this differ from the increasing use of individual genetic testing and other kinds of specialized blood tests to guide treatment? So just as an example, I mean, our listeners may be aware of the fact that contemporary cancer treatment often depends on identifying the specific genetic alteration in an individual cancer patient's tumor, and then using drugs that we know work against that kind of genetic alteration. This is still different from that approach, yes?
It is. And so all of us do use the word personalized or precision in many different contexts. So I'm glad you brought that up, Ira, because I think of that as precision subgrouping. In that case, doctors and clinical geneticists and all the other people involved are trying to guess ahead of time with more precision what's going to be the best treatment for that person with cancer. What personalized trials are doing, or personalized treatment, is we're actually using the treatment exposure and randomization to figure out the best response or the best treatment effect for that patient. So one is still trying to predict what's going to work well for you, and the other is actually testing scientifically what did work best for you.
Okay. So you gave an example, or I threw out the example of somebody trying a couple of different blood pressure medicines and measuring their blood pressure. Can you give us a sort of more general sense of how these personalized trials are set up and how they're structured?
So in general, to be a good place to be thinking about personalized trials, it has to be something that we can measure repeatedly, preferably in the patient's real life. So you can't do this with a broken bone, because we can't go and try different types of repairs. Once it's repaired, it's repaired. But as a clinical psychologist, most of the problems I try and help patients with have multiple possible treatments, and we don't have a universal cure for that problem. We don't have a universal cure for depression or obesity or difficulty with healthy physical activity, or asthma or pain. And so if you don't have a universal cure,
can I interrupt you
please.
for 1 second? When you say a universal cure, you mean a treatment that works for everybody?
Yes. If you have a treatment that works for everybody, we don't need to do a personalized trial, because you just have to get that person on that one single treatment, and then they're cured.
Right. So if you have a particular infection with a particular kind of bacteria, we know what kind of antibiotic to use, and we're done with it. This is for conditions where there's some choices to be made, right, by the doctor and the patient.
Yes. Exactly.
Okay.
Or
and
where
the
there are
kinds of things that
treatments that work for many people, but not for every single person. And this is a faster way to figure out scientifically which is the best one for this patient in front of you.
Right, but you said it hinges on being able to have some measure of success, right? Whether it's the blood pressure going lower, or the mood improving in depression, or some other thing that you can measure repeatedly.
For patients with asthma, or patients with AFib. So it has to be something that when someone's had a treatment, we can see how they responded. if we can't figure out how they responded, then we can't really measure which of the treatments is best for that person.
And so how does this get set up? What do you actually do? Or what does the patient do?
What we're envisioning is that physicians are first educated about this program, and so they have as easy a kit as possible that they can hand a patient, so that when a patient comes in and says, I'm having some fatigue, and I don't know if I should be taking a complementary and alternative medicine, or I should be trying to use light therapy to fix this, we can say, we have something for you to try. And you're going to try a light therapy glass in the morning, and sometimes a melatonin pill. And at the end of it, we'll tell you what worked for you and what didn't. So it will, we hope at Northwell, be increasingly that for those conditions that patients often struggle finding the right answer for them about what helps them manage that symptom or condition or risk factor, we will have a ready and easy way for them to try some of the evidence-based treatments that work for some people, but for that patient to figure out if it works for themselves.
And do you routinely use placebos or sugar pills so that the patient doesn't actually know what treatment they're getting?
We actually asked 500 patients across the nation how they felt about placebo in these kinds of trials, and they said they were pretty comfortable with them as long as their physician could be made aware of what they were on, either during the trial or after. And so, yes, occasionally, when it's appropriate, we do. So if someone is stage 1 hypertension, that might be appropriate. But if someone is already on medication and reporting that they're having a lot of side effects and they want to be trying different types of antihypertensives, then we might say that's not appropriate to try a placebo.
Right. Because at the end of the day, we do know that it's important for people to be on active treatment for some of these conditions.
Yes.
Give us a sense of what the range of conditions or illnesses your group is approaching with this kind of systematic approach.
So for sleep, problems with sleep duration, we're trying a placebo-controlled melatonin personalized trial where someone can try having placebo or a low dose or a high dose of melatonin, and then they're being monitored for how long they're in actual sleep with a passive monitor. And then we can see if they also report problems with grogginess or other things, because we ask them each day if they're having any side effects that they'd like to report to us. And that way someone can tell if melatonin is or is not a useful complementary and alternative medicine for them to use. We have a stress management trial that we're about to launch. As you know, for some people, meditation is a very stress-reducing technique, where, ironically, for others, it actually creates anxiety as they try and empty their mind. They start thinking more and more about their problems. For other people, exercising is a great way to have stress reduction. And for yet others, exercising causes them extra guilt and anxiety and concern, and it does not reduce their stress. So we're just in the process of getting the stress management trial running. We have already finished a chronic lower back pain trial where we randomized healthcare workers to have a massage that's known to help with lower back pain, or yoga supervised that's known to help with lower back pain. But both of those treatments, for some people, actually increases the back pain. And so people were getting those at different times, and then they could see if they got better with the yoga, or got better with the massage, or got better with both, or got better with neither. We've already run the antihypertension trial.
Yeah.
Yeah, because for many of us, when we have a problem, we try something, and we don't know if we should keep going with it, go longer, have a little more of it, or if the pain. One of the fascinating things we saw with massage was for the people for whom massage did not help their chronic low back pain, their pain increased 2 days later. And you might not attribute that to the massage, but we can do that because we randomized you to get massage, get yoga, get massage, We could say, you reliably had more pain 2 days later. So you should
and
not
you're
be
tracking
using
this, right? You're tracking this in a much more
Yes.
methodical way than people would necessarily, as you say, associate 2 days later. Who remembers what happened 2 days ago, right?
Right.
Yeah, that's interesting. And just to be clear, when you're saying you're doing these trials, you're inviting individual patients to do their own trial with these different sets of treatments.
We are.
Yeah.
Absolutely a collaboration between the practitioner and the patient, and in this case, the researcher, as we pilot the procedures and make sure that it's not too much reporting for the patient or getting something mailed out to them or back isn't onerous. So we're really trying to work out the procedures that this can move into clinical practice.
Our listeners have probably gotten a lesson in the statistics of large clinical trials, reading about how the vaccines for COVID-19 were tested in tens of thousands of patients, and we looked at the difference in how many people got COVID in the vaccine group versus the placebo group. And there are all kinds of sophisticated statistics that get done to compare different rates in different groups. I'm struck by the fact that if you're doing this sort of, well, I'll call it experimentation, or at least alternating therapy in one individual, how do you get that level of reliability of the results? How do you know that it's not just chance associations that one day they felt better and you therefore misattributed it to the pill they took the day before?
We calculate statistical power, or that we had enough data in order to rule out chance, by the number of measurements we had. So in large vaccine trials, it's by the number of people you have, but this is a different way of doing it, and it's by the number of measures. And then to check that it wasn't chance, that someone had a bad 2 weeks, the 2 weeks that they had the massage versus the 2 weeks that they had the yoga, we repeat the exposures. So they're formally called a multiple crossover trial design. And so you get in random order, say 3 times exposed to massage and 3 times exposed to yoga. And then we can look across time, and if there's clearly a signal that each and every 2-week block that you got massage, you did worse than when you got yoga, we can start to conclude, based on the statistical power we did ahead of time and the number of measurements we had, that you in fact had a statistically better treatment effect to yoga than to massage.
And so it's not just you try yoga and then you try massage and you figure out which, on the basis of one exposure to each, which one works better. It requires that sort of multiple back and forth to
yes.
Get that reliability.
And exactly as you said, with prospective measurement, which means if we say we want to know your pain each and every day, we're getting it for 14 days in a row. We're not just asking you once at the end of the trial, so did you feel better on massage or on yoga?
And how do you actually facilitate those that data collection? You give people an app on their phone or something like that?
We do, yes. So we have texts. Patients told us they actually prefer texts rather than apps. And so they get a text and they just type a number in for the pain. For the blood pressure, we have Bluetooth-enabled blood pressure machines, so they just have to measure their pressure and they don't have to type the number in anywhere. So we're trying to find all of the barriers to doing this easily and making sure that they're sort of baked into the way that we do our business.
Yeah, I want to ask you about some of those barriers, because in the example you gave earlier in our discussion, you set it up in such a way where I thought, well, who wouldn't want to do that, right? It's sort of like, are you interested in finding a drug that is going to be more effective and have fewer side effects? Well, sure. Like, who wouldn't want that? But there must be some challenges to doing this, or we'd be doing more of it. So what do you see as the barrier to doing this?
Some is everyone understanding what this is. That is one real barrier. So we really want patients to hear this isn't exploitation or experimentation on them, but rather a collaboration. That if they want to know the least amount of drug that they can be on that gets them the best effects, that they need to do this. Certainly a difference is patients have to, say, take their blood pressure every day for 12 weeks rather than the doctor takes it once and then when they come for follow-up, the doctor takes it again. So there is some asking the patient to record symptoms that happens between the two. There's heavy-duty statistics that have to be done before the trial starts and then after to return the results in a way that both the clinician and the patient find useful. So the barriers have been education, patient time, and statistician time.
As a practicing physician myself, I certainly wouldn't know how to do this in my office on my own with my patients. So I would need to get the help of somebody like you or your research team to support my ability to do this. Is that how you're approaching this?
Our dream is to automate it and make it virtual. So our dream is that you, Ira, when you're in your office and you've got a patient who's going for the first time on an antihypertensive and you think it's essential and you think the 3 first-line antihypertensives that we're using are appropriate, an ACE and ARB and a diuretic, you click a button when the patient wants to do this, and that sends a box that has the blood pressure kit and the medications in a Bluetooth-enabled pill bottle out to the patient, and the texts start coming, and at 12 weeks, you get a printout of the findings for your follow-up meeting with that patient.
Wow. Yeah, that sounds great. Who's going to pay for that?
We hope that eventually we'll be able to convince the FDA, certainly for certain expensive drugs, having a relatively quick and precise answer as to whether that works. We've had the FDA say that they would accept these kinds of trials when dosing is needed for drugs. For patients who are using complementary and alternative therapies, we're hoping that they may eventually see the value, that paying $50 to find out should they sit in front of a light box for 30 minutes every fall, does that work for them for SADS or does that not, is a useful thing to invest in to find out the answer, or in fact to move on to a different treatment if that's not actually helping them.
I'm glad you mentioned the alternative treatments because I think my experience is similar to many physicians where patients come to our offices taking all kinds of stuff that we haven't prescribed, that they've read about on the internet or heard about from a friend. Those are often very difficult conversations to have about whether these things really work or not, or the value of taking them. Do you see this as a way to kind of inject some objectivity into the use of these alternative treatments?
I do. And for patients to see if, there are some people who do have a therapeutic response to St. John's wort for depression. The estimates say it's about 17%. So there are maybe 83% of people who are taking St. John's wort, who are paying for it year after year, and maybe it's actually not helping them. So this would help a patient find out, is it worth spending the money because I'm getting help from this, or is it not? Tell you 2 other interesting use cases, if I may.
Sure.
There are many patients who feel that they get muscle ache when they start taking a statin.
Oh, you read my mind. That's exactly you read my mind. I was thinking the same exact thing. So just for our listeners, that the statins are the class of drugs that are very widely prescribed to treat high cholesterol. So Lipitor, Zocor, Crestor, all of those are members of the statin class. And yes, so you were saying.
And you, Ira, probably know better than me. It's something like 3 to 7% of the patients in the clinical trials of those statins had real treatment-related muscle discomfort that caused them to need to stop their drug.
Yes, a very low percentage.
Practice, yeah, it's 40 or 50% of patients who believe that they feel a muscle discomfort and believe that it's related to their medication, which it could be if they're one of the 3 to 7%, or it could not be if they're not. And so with others, we have run a placebo-controlled statin trial and measured cholesterol once a week, but measured feelings of fatigue and muscle pain daily. And about 85% of patients at the end of the trial discover they are having a lot of muscle ache and pain. It's just not related to the statin, and so go back on the statin.
Yeah, and just to underscore why that's so important is that these drugs are really remarkably effective at reducing the risk of bad outcomes for people with heart disease. And so this is a real problem for practicing physicians who feel compelled to take patients off of these drugs that they would really benefit from because the patients are often complaining of these nuisance side effects. So that would be great. Yeah.
Yes. Another one, as you know, many of the patients who are in our skilled nursing facilities or nursing homes, 14 to 16 drugs daily. Yeah. And quite frequently, they have new symptoms. Now they have insomnia. They didn't have insomnia before, now they do. Or they have anxiety now. Or their cholesterol is rising. And you can do a disimplementation personalized trial where you randomize that patient to be measuring the things that the geriatrician is concerned about, as well as the problem symptom, and you randomly take one drug off and see if you change the sleep problem without affecting the indication for the drug they were on. It's very hard, as you know, for a clinician to decide, I put you on a blood pressure medication, then I put you on a second, then I put you on a third. Now I think you're controlled. Now I've added a beta blocker for a different indication and something else and something else. Is it safe to take you off, say, the first antihypertensive that you never showed a particular response to? Is it okay to do that? Well, we can measure blood pressure and see if taking them off that ACE inhibitor changes their blood pressure or changes the side effect that they've started to having, possibly because of polypharmacy.
Right. No, I mean, what I'm taking away from this is that I think a lot of physicians do this sort of what I like to call tinkering with people's medicines, but we do it in a very crude and informal way that often doesn't lead to a clear answer. And what you're offering is an opportunity for us to do this in a way where we can get a really highly reliable, scientifically valid answer to a real clinical question.
Yes, that is our mission, Ira. That's what we're going to do for Northwell. We're going to make sure that this gets in the hands of clinicians and patients so that they can find out what's working for them and what's not.
So, Karina, this has been absolutely fascinating. Where can our listeners go to learn more about this or even get involved in a personalized trial of their own?
Thank you for asking me that, Ira. We have a website that is www.personalizedhealth.org. And on that, we have information about personalized trials, and we have the research studies that are currently open. So patients are welcome to click those links if it's a symptom or a problem they have to see if they're eligible and if it's something they're interested in participating in.
Just give us that URL again. It's personalizedhealth.org.
Yes, it's www.personalizedhealth.org.
Terrific.
We also have an email address for anyone who wants to get on a wait list or tell us about a symptom that they're interested in having a personalized trial designed for, and that's personalized trials, all one word, at northwell.edu.
That's terrific. And we'll post these, the email and the URL on our website where we post the recordings of each of these shows. Karina, thank you so much for an absolutely fascinating session today.
I'm delighted to be here with you, Ira, and we look forward to the next topics on Well Said.
Well, thanks. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.